ask, because all these topics like pulmonary edema, pleural effusion, they all are very much related topics, right? And today we'll be watching certain X-rays, which we have seen in past, but today we'll be looking at it with different perspective. Why should be quite okay? Because the voice meter, which is showing over here, it is absolutely fine. So Akshat, if the voice you feel is low, please check your speaker volume. I'll just show you what happens is over here. Because when I speak, so in case if I'm very loud, see I am very loud, it is totally red. Right? When it is red, it distorts the voice. So till it is going in yellow, green and yellow, it is totally all right. Back. So the topic is pulmonary edema. How many of us are here? 45. We'll wait for 2-3 minutes. Yes, I got few mails. Yes, it would happen that the passcode, our passcode 252525, and that would be activated at around 10:27, 10:25 to 27, as soon as my previous lecture is complete. Time. So as usual, this is what we are talking about, and just to be clear, lungs, they are covered with pleura. And over here, there would be the heart. We'll go for revision. We'll have a separate session for the entire revision. So over here is the heart. And heart is covered by pericardium. Heart is covered by pericardium. Now, whether it is pleura, which is covering the lungs, or it is pericardium, which is covering the heart, or it would be the third, would be the peritoneum. Peritoneum. This will come in abdomen. All of them will be having 2 layers, visceral and parietal. So peritoneum will be covering, right? Peritoneum will be covering abdominal organs, that is GIT, that is, right? Pericardium will be covering the heart, cardium is heart. Peri means surrounding, right? So it is surrounding the heart. And pleura, that would be surrounding the lungs, right? And peritoneum will be surrounding the abdominal organs. So when it comes to abdomen, GIT and the one lung covering heart, lungs covering heart. Lungs are not covering the heart. Lungs and they both are separate. Right? The heart is in between. Lungs are surrounding. Right? So that is how this is there. So pericardium is covering the heart and pleura is covering lungs. They all are separate. And if you really remember, we talked about mediastinum. What is mediastinum? Mediastinum is the space which is present between the lungs, correct? Which is present between the lungs. So that's the space. It is that space in which the heart is present. Got it? Right? And then when you are watching from the side, there is anterior mediastinum and posterior mediastinum. So it is in anterior mediastinum, the heart is present. That means that when you look from the side, heart is present over. This is anterior. This is anterior. This is posterior. Correct? And you will find the aorta going like this. This will be more clear when you will be watching the CT scan. Right? But still, this is the seen even in the normal X-ray chest also, the lateral. So this is like aorta, when we say that it travels into the anterior mediastinum and then it goes towards posterior. Because how the aorta comes out? As soon as it comes out from the left ventricle, from anterior, it takes a turn and it goes behind. Right? So that turn is arch of aorta. This turn, this is arch, right? This is arch. And from anterior, it goes into the posterior, because when you'll be watching it on the CT scan section, right? When you take a section, you will find that in a section, when this is the vertebra, here is the location of aorta. Correct? So this is the location of aorta. If you take a section over here, the aorta would be found in the anterior intestinal. Right? Anyway, we'll just 1 or 2 days, we'll be taking the CT scan. All the sections. I mean, we'll start with this almost at the level of neck, right? Just below the neck, because neck structures we have not yet discussed. So no point in discussing the neck sections. We'll be taking from the apex of the lung and all the way will reach up to the level of diaphragm, so that you should be able to visualize that how the structures are made. Right? The main content is nothing, but when you talk about, you take this section, so when you see, yes, on both the sides there are small air pockets, because apex of the lung is small. Right? When you go down, you'll find that they become bigger and bigger. But this is the area where there will be major vessels. The superior vena cava will be coming from the top, that arch of aorta, and especially this is the arch. And when you cut the arch at this point, right, the shape would not be circular, but it would be big oval. Right? This is a tube, and when you are cutting it from the top, so that's how it would look like. So when at one point of time, when the arch is like this and you cut it over here, you'll be getting 1 and 2. One is the ascending aorta, the second is the descending aorta. So all these things we'll be watching from 3 different planes, and so that you should be having a 3D visualization of what exactly are we talking about. Once this part is clear, then deciding about various diseases that comes absolutely. And then straight away from that point, we'll be shifting our gears for cardiology. Right? Because by the time when we'll be discussing all the chambers over here, all the sections, right? So you will be having very clear idea that which chamber is moving in which direction. So that would be what we'll be studying. It will be a totally normal CT scan, no abnormal. Right? After that, when we'll be discussing the congenital heart anomaly or any of the other anomalies, so that is when you'll find, yes, there looks like a defect. Right? And then we'll see that after surgery, what really happened, how the artificial valve was placed, or how the occluder was placed in case of atrial septal. Because it is necessary, no? If this is the heart, and if there is a gap in between, so we need to occlude that. We need to fill that gap. So how these gaps are filled and what are the various methods available. And I'll show you the real things, so that when they are put, so it would stay over there for long, made up of titanium. So similarly, there is a difference between occluder, which is used for ASD, and which is used for VSD. ASD and VSD. Right? Atrial septal defect, so hole in the heart at upper level. Ventricular septal defect, hole. Right? Don't worry, all of them will be discussed. So this would be our plan for, say, maybe this week. From next week, we'll be starting cardiology. Right? And yes, 1 day for the revision, week for full revision. Right? From the first, all the 14 sessions, whatever we discussed in last 14 sessions, we'll discuss everything. Right? No doubt it would be at a high pace. Okay? So for those who have joined later, you can just go through all of them revision can be taken only after we complete the respiratory system. Here, before cardiology, definitely. That's what I say. RS we complete, then do the revision, and then we will go for cardiology. Okay? Oh, I think it's time. Stop. Right. That's the topic for edema, pulmonary edema. Coming back to our basics. This time you'll find things are much easier for you know this part. When we say pulmonary edema, it's nothing but this is our alveoli, correct? And when the fluid is over here, fluid in the alveoli, right? Normally this thing area is kept completely dry. Gas exchange, na? But when the fluid comes over here, so that is called as the pulmonary edema. When we'll be discussing radiology, if you remember, we talked about curly V lines. Curly V lines. They will be watching it in slightly more detail. No doubt. At least today, what you will see, that much it is expected that you should be ready. So that is, we'll see those curly V lines very clearly. Last time when I showed you, so it was a bit difficult, right? There were only very few scanty, very thin curly V lines were there. But today what you will watch, that would be very common. Because it is the hallmark of, it is the main sign of pulmonary edema, right? And we'll see the reasons of it. So here it is, that fluid is coming over here. Now why fluid should come? Fluid can come, because normally no fluid can come. But this fluid, it comes, here is, who is here? This is the pulmonary capillary, right? Pulmonary capillary. Normally, this pulmonary capillary is all this, right? RBCs, they come tumbling over here. They say, take the CO2 and give the oxygen. They will happily take the oxygen and they go. No complication. But when the pressure increases, because this entire system is a very fine, beautiful balance between two pressures. Pressure, one, what is called as the hydrostatic pressure, right? Hydro, water, right? Hydrostatic pressure. So this means this is the pressure which is exerted on the walls. So obviously, when the blood pressure is high, so then pressure generated on the walls will be more. When we say blood pressure is nothing but the amount of pressure which is exerted on the walls is the blood pressure. So this hydrostatic pressure, so basically it is hydrostatic pressure. We lovingly call it blood pressure. But actually it is the pressure which is exerted by the water which is present into the blood. Those cells, so they was like musafir, right? They will just keep on tumbling and moving, right? They don't exert any pressure. It is the water which is exerted. So in other words, plasma. Right? So that is what is called as the hydrostatic pressure when this pressure is increased. When this pressure is increased, then the other one, that is called as the oncotic pressure. Oncotic. So this oncotic pressure is like, it tells कि नहीं, क्यों बाहर? It just stay here. They love water. They'll attract the water. They will attract the water. When this is, so they love water. But when this pressure is decreased, so then water would say कि बस यहाँ पे अब कौन है अब, right? And they will start. So here it is. This is how it goes. And this oncotic pressure, as such, is dependent on protein. And protein is made by whom? By our liver. Which one? Which part? Because oncotic pressure is that pressure. This is the artery. right? Or you can say arteriole or capillary. In other words, any of the blood vessel. In the blood vessel, in anywhere in the body, when the fluid is moving, right? Fluid is moving. I'm using a very gross terminology, fluid. Reason, I don't want to restrict yourself to just one thing, that first it is into the blood. No, wherever there is fluid, in the fluid, if there is protein, so then this protein it loves water. Protein and water also loves protein so much. So when they both are there, they'll say, no, we'll stay together. Right? We'll not go. But when the protein is not there, the water will say, मैं क्या करूं? Right? The water will start moving. So the point is, right, these jokes apart, protein, it holds the water. It holds the water. That's why technically it is called as the colloidal oncotic pressure. Oncotic pressure. There is beautiful physics behind it. But basically, this is a colloidal oncotic pressure, physics and the chemistry of it. So it holds the water. So this is one pressure which is keeping the water inside. Sorry. Which is keeping the water inside. And then there is heavy duty hydrostatic pressure. Right? Hydrostatic pressure. Hydrostatic pressure tells chalo chalo baar. Right? So this pushes water out and this one takes the water in. Right? Don't confuse between hydrophilic. Just for our understanding, you can say this is hydrophilic. But technically speaking, it is different. Right? So Tanmay, we can remember it like that yes, this is hydrophilic. But truly speaking, we just remember that it holds the water. Technically speaking, it holds the water. So remember it like that. So that would be much better. I'm using the word holds water. Okay. So when there is good balance, neither the fluid is going out, nor the fluid is coming in. And so they both are at peace and continuously that fluid flows. In case of blood, over here, in case of pulmonary capillary, it is the blood which is going. They just exchange the oxygen, carbon dioxide, and the life is good. Things are going fine. But when the hydrostatic pressure increases, that is, so then the fluid would be pushed in. Because pressure is more. Or when the oncotic pressure drops, then also fluid goes down. Because then water tells कि अपना कौन है, जाओ, it goes. Basically, these are the two main reasons. Now diving deep. When we talk about increase hydrostatic pressure, the most important reason of all is left heart failure. Now I'll show you some of the X-rays where there would be very classical pulmonary edema, but without left heart failure. That means immediately you'll find, if the heart is normal, everything is normal, that means this is not because of left heart failure. And you'll try to find out Curly B lines not present, okay, time. So this is where it's, right? You just put the probe on the abdomen and you know that what's the reason. The kidneys are failing. First, we come to left heart failure. Very easy understanding. This is the area. This is left atrium and this is the left ventricle. Lungs are over here. Lungs are over here. Blood, purified blood, that is oxygenated blood, will be landing on the left atrium. Rest of the circuit right now we are not drawing. So it lands into the left atrium. So very happily lung pushes the blood into left atrium to jao, right? This oxygen ka prasad send it to the entire body. But over here, these dwar are band. Darwaje band hai. Kyun? Either इतनी भीड़ लेफ्ट एट्रियम में. Why there is भीड़? Because आगे का दरवाजा, mitral stenosis. This is the mitral valve that is closed. Why it is closed? Well, it is stenosis, mitral stenosis. It is a very narrow opening, so only dhire blood is going out. So that means there is mounting of pressure into the left atrium. When there is left atrial pressure, this blood will say कि अच्छा लाइन में खड़े. So पीछे वाले धक्का, then धक्का मुक्की. This is what is called as the back pressure. Back pressure. So much so, at one point of time, that back pressure is generated into the lungs, and that back pressure will come all the way into this our alveoli, and these are the pulmonary capillaries. And when these pulmonary capillaries are telling the blood के जा आगे, right? ये कह रहे हैं नहीं साहब, आगे तो जाम है. So that means blood is coming from the back, so now the pressure starts rising. And then when the pressure rises, that is the hydrostatic pressure. And it pushes the fluid. It pushes the fluid into the alveoli. Now there is no damage. Remember, there is no damage. So that's why this fluid would be a clear fluid, and that would be the transudate. Right? That would be the transudate. So whenever we are talking about left heart failure, left ventricular, or I mean at this point of time, let's keep left heart failure. Then we'll go for left atrial or left ventricular. Left heart failure, left side of the heart is having any trouble, whether that trouble is because of the conduction system, or the valve, or it is because of narrowing of some vessel, whatever that is. Right? But when the left side of the heart is not functioning, so then the pressure increases and the fluid which will be entering into the alveoli. Into the alveoli, it would be a clear fluid. It would be, you can remember it like it would be a transparent fluid. Transparent fluid. And when we say transparent fluid, this means it is just a fluid. There are no RBC, there are no proteins, nothing. Because the fluid which is going into the alveoli, these are the endothelials, right? These are the endothelials. So they have not given the way. Right? So that's just that the blood, it trickles this fluid. That fluid just passes through because of the pressure. Right? Because of the pressure, it crosses, so it reaches. So this is a transudate. So we can say it like that left heart failure. It leads to increased hydrostatic pressure. It leads to increased hydrostatic pressure in pulmonary capillaries. The rest, you are smart enough to understand what happens. So this is one in case of left hydrostatic pressure. This is the first thing. Now the second thing is very interesting. There are certain points, when you remember, if you by any chance, if you speak that thing in exam, you will be miles ahead as compared to your competitors. This is one of the things what is called as the positional. Positional, that means what's the position of the patient? Nocturnal, that is at night. When the patient is sleeping and then suddenly, right? And then he is at night. This is nocturnal, at night. So at night, when he is lying, then this thing happens. Why this thing should occur? Because when the patient is lying, you see, normally when you are standing, it is the gravity, right? So the blood is pulled towards the lower limb. Blood is pulled towards the lower limb. Now from lower limb, there is one muscle. In your calf muscles, there is one muscle which is called the soleus. Soleus. Soleus is second name. Second name is second heart. पता नहीं लास्ट बैच में किसी ऐसा दो हार्ट, मैंने कहा नहीं 3 हार्ट, because this soleus is present in both of your calf muscles. So now you are at liberty to So he said, we can give our heart to 3 persons. I said, then be very specific, na? Because here the original heart hai bada. So there are 4 chambers. So give 4 chambers to different person and these 2 to different. मैं कहा फिर जो मार पड़े फिर वो खुद देख लेना. Anyway, so this soleus is called as the second heart because it is the heart. It is considered as heart because these vessels, right, these veins, they are squeezed by those soleus muscle and the blood is pushed because gravity is acting on it. Arteries to dham blood, they will take it down, but from below when it is to be pushed, when person lies, gravity goes, right? So blood comes beautifully, right? So it is like there is increased venous return. When there is increased venous return, what would happen? This venous return, this will be going all the way to vena cava. From vena cava, infra vena cava. From infra vena cava, it will go to right atrium. Right atrium to right ventricle. Right ventricle to lungs. There is more blood. So when there is more blood, that means there will be development of this pulmonary edema. That means there would be more fluid collection into these alveoli. And that is the reason person will become dyspneic when he is. Typically, you will find these persons आधे ऐसे लेटे. They'll never पूरा नहीं सोएंगे, right? Their bed is elevated. It is they'll always say, whenever the patient is dyspneic, they say bed thoda upar. So this would be the position. And for whole night, right? They will be just say sleeping like this, elevated. They feel it so comfortable. Because now less venous return. So this is one. Acha. I would like to show you one picture. Now it is over here, but this is very interesting. In such patients, yes, go ahead. Venous return is backflow of blood. Yes, venous return is what? When from lower limb, when the blood is coming to our right atrium. Less venous blood is good or bad? When the person is healthy, that is absolutely good. You know? That's why you are doing calf muscle exercise. Because if your calf muscles are good, that means the blood would be coming back nicely. If blood is not coming back nicely, then person develops, we are deviating slightly, person develops what is the varicose veins. Varicose veins. Varicose veins means these are tortuous, yes, tortuous these veins, right? They are like this. Then because there are valves, right? When these valves they give way, so that means pura blood upar ja raha hai, but it is causing the pressure downwards, so then vessel becomes tortuous. So much so, then the surrounding vessels, right, all become tortuous. Pure palm mein blue. Then it turns black, right? The treatment, they just strip off, they just remove these vessels, right? They are surgically removed. They can't. I mean, they can go. There are two methods. One is the conservative treatment. Second is the surgical treatment. So in conservative treatment, the attempt is made that you make your muscle, because if it is the beginning, then it is said make your muscles powerful, right? If the calf muscles are powerful, so they can smoothly push the blood back, nothing would happen. Then, I mean, say there are, what I am telling you is this is a bit costly solution, but there are easy, the massage guns they are called as the world's best, it is called as the Theragun. Right? Theragun. The specialty of this gun is that you connect it with your phone, right? And then when you start doing it, I mean, if after coming back from marathon, there is a complete routine. Right? So on calf muscles, first you start with the foot, and then you set that setting, and in your iPhone you just watch that what's the level, and then it is what is called as the impact gun. It will just push like this, right? It's a very powerful gun. So when it pushes, it actually improves your circulation, and it removes that lactic acid accumulation, and so that it goes back, right? So And connected with Bluetooth, so you'll be having a visual that yes, how much pressure are you exerting? Very scientific. This is something which is used even in Olympics, but cost is very high. But impact guns, they are available even on Amazon. If you are really doing exercises to that very high level, then it is good. Right? You can use that. Let me know, right? I'll suggest you even some other options also. But if you are doing that, if your lactic acid accumulation is to that level, then and then go for these things, right? Otherwise, don't use it. Right? Can varicose veins go away? Yes, this is the conservative method. Then there are compression socks. There are compression socks. Because see, normally it is said that varicose veins किनको होती है? Those who are very varicose veins, they can occur to very सबसे ज्यादा traffic police. If you stand more, then it can occur. That's why in old age it is said that you can tell your mom, etc. Exactly, that's what I'm telling you, right? You can tell them कि नहीं आप ज़्यादा खड़े मत करो. Right? Why does the person sleeps in a sitting position? Because when the person is lying, right, so this venous return will be straight away will be reaching to the lungs. So when it is reaching, so that is the extra blood which will that will increase the hydrostatic pressure, will push the fluid into the heart, making calf muscle strong, avoid heart pain. Heart pain ka pata nahi. Heart pain we can't say because there are various reasons of heart pain, but yes, definitely if your calf muscles are strong, it will make your entire circulatory system power. Right? Circulatory system power. Varicose veins के लिए sleep position is not very important. It is the compression. There are socks which are available. They are called as the compression socks. Have you seen footballers? Footballers जो पहनते हैं, even in marathon, when it is a real full marathon, so we wear these compression socks because these compression socks. So these are your calf muscles, right? They will be like this. Say the compression. There are various types of compression socks. So one which I am wearing, they will be having 3 bands on the calf, and then it will be having 1 band, the vertical band like this. So when stockings, they are like, but say the stockings which female wear, right? They are like more or less. Don't feel bad. I mean, what I mean to say is that they are like that legs should look good, but they are not like that. These bands, right? These are the very scientifically designed, in which there are some very tight bands, right? Elastic bands, so they will be helping for this. Exactly. So that's what I was telling. That skin colored stockings, etc. No, they are not having this. These compression socks, so you will find that is completely different. And plus the vertical ridges. The vertical ridges, they also help a lot. And plus they'll be at the ankle also. It could be like that. And over here there is cushion because that is where the impact you are running. So these are the compression socks which are used for the vein. So this is all of these things, they are coming. Whether you use the impact gun or you use this compression socks or you do the reverse massage. Reverse massage is when you are doing it into this direction, right? You will never be doing massage in this direction. Going from top to bottom, right? That would harm the patient. It should never be done. It has to be from below to up so that you are improving the circulation. Okay? So all these things, they come under what is called as the conservative therapy. If a person doesn't take treatment for varicose veins, the worst thing is varicose veins, they are the worst thing as the age increases, and especially for females, because their skin is very thin. When the skin is thin, so gradually it starts accumulating. Later on, it will lead to complications in the form of infection and then the blood pooling. And then once they start breaking, right, you will find that the entire leg, foot, calf, they become totally black. And at one point of time, it occludes. So then there is no, because it gives so much of pain, and still if care is not taken, so then tissue necrosis starts. Because finally this blood is what? This blood is that in which there is accumulation of carbon dioxide, which is not good. जिम के लिए बहुत, जिम तो छोड़ो यार, जिम क्या, अपने घर में ही सिर्फ 200 रुपए का एक, इट इज कॉल्ड एज द योगा बार, मुश्किल से 200 रुपए में तो दो. सो टेक दिस, कहीं पे भी सपोर्ट लेके, जस्ट पुट योर फुट लाइक दिस, राइट, लाइक दिस, एंड जस्ट up down. When you do this, it is one of the best exercise for calf muscle. So if those veins are prominent now, छोटी vein का बहुत tension होता है. That would be short saphenous vein. इसका क्या tension? This we are talking about the great saphenous. We'll be talking in more detail. They are called as the yoga break. Yoga break. लेग डे पे जो लास्ट में आप काफ मारते हैं बस. I mean, various methods. Let's say if I go to gym, right? So then there is, this is like what is called as the leg press, right? So on both the sides, right, you got those heavy weights, right? And then you are doing the full leg press. But then उसके बाद क्या, अब आपका जो half of the leg, right? Half of the foot, not half of the foot is out, and then just do this, right? When you do that, yes, that is also one of the calf. Jumping makes calf muscle. I would say skipping, right? That is also one of the very good exercise. And say initially, say I do skipping at the rate of 160 to 170 per minute. Try to achieve even, right? But at least पहला up to 100 skips without any halt. हर बार रुक गए ऐसा नहीं. And once you know, once एक बार आपकी speed आ गई, then you can go for crisscross, right? Then you can go for side to side. There are so many exercises, right? Jumping rope, and you can go for those jumping ropes which are with the ball bearing. They are slightly expensive. Normal jumping rope, which is with a heavy rope, that will cost you about 300 rupees. 100 रुपए में भी मिलते हैं. But some are extremely bakwas, right? मतलब they'll put extra load on your heart, but then some of them, they are with ball bearing, so they move at a very high pace, and that wire, that rope is not a rope, is a thin wire, so it is impossible to see that wire when they, and it really moves at a very high pace. So that is a very good cardio. Okay, chalo, right? So that's the reason that venous return is so vital. What I was about to discuss, it is called as the HF cells, or the heart failure cells. Heart failure cells. First I'll show you. Say this, right? This is a picture of alveoli. Okay? कहाँ पे है alveoli? This is our, sorry, this is one alveoli. ये दूसरा alveoli. ये तीसरा alveoli. This is a fourth one. This is a fifth one. Forget about all other alveoli. This is one alveoli. How do we know? See these cells, right? These cells. इनके shape देखो, right? All these are what you are watching. It is in fact like this. These are simple squamous epithelium, right? They are simple squamous epithelium. So squamous means something which is flat, right? Simple means one layer. Simple means one layer. Squamous means flat. Epithelium means epithelial cells. What I drew, और यहाँ पे जो दिख रहा है वो तो बिल्कुल ही अलग है. You just can't see like that because the cells cannot be seen. What you can really see is only the nucleus which is inside. So that nucleus is like this, like this. That's why the hallmark of this cell is you'll watch dark, flat nucleus. This is the typical of dark, flat nucleus. When in other type of cells, when it is a cuboidal one, तो round nucleus आएगा. When it is columnar, the nucleus would be elongated. Right? This is what we see into histology. Purple is that nucleus. You are right. That is the nucleus. So from the shape of that nucleus, we decide that this is the simple squamous epithelium, and that's the single lining of epithelium. What happens is that when the pressure increases, तो यहाँ पे तो कभी blood आना ही नहीं चाहिए. Blood should not come. Right? Here, so this is the area only for अपना simple oxygen, carbon dioxide. Right? This area remains dry. Here in this case, because of any reason, it could be either infection, it could be because of carcinoma, that we cannot make out from this particular slide. But for any reason, when there is exudate, right? Exudate, this means when there is stretching, and these cells, they stretch, and in between this gap is created. And through this gap, not only the fluid, but the RBCs, but WBCs, proteins, all cellular material, they come inside. And this is when we'll call it exudate. When it is exudate कब हो सकता है? When there is inflammation. When there is, they shrink. That means the entire wall stretches. So they because of that stretch, right? Because of wall stretch, they all are now apart from each other. There is a gap which is created. So exudate. Last time तो ये discuss किया था. Transudate and exudate कितना detail में लिखा. अभी तो याद होगा. Exudate means RBC, WBC, proteins. It means not fluid, but बाकी की चीजें भी when they enter. That is called as the exudate. याद आया? You remember it, huh? Okay. Right? So that comes. When that thing comes, this is the after effect of it. Right? What has happened is red what you are watching, right? All these are RBCs. Now when the RBCs come into this area, lung, मतलब alveoli तो पागल हो जाए. ये कौन? Right? तो उसने फोन किया. किसको? WBCs को. Body के defense system. तो भगाओ इनको. So they sent the macrophages. Macrophages, they are like that, there is a game, right? Goblins go, right? And they keep on eating those dots. Pac-Man. Exactly, Pac-Man. So these are macrophages, they are exactly like that. So those macrophages, उन्होंने आके RBCs को खाना शुरू. They started eating. When they ate, RBC contains what? Red blood cell that contains heme and a globin. Right? Globin is a protein. Heme तो पूरा iron loaded. Right? There is iron. So that thing, जब बेचारा RBC टूट गया, so then that iron is released. Right? And that is released into the form of what is called as the hemosiderin. Now, whenever you see any of the blood report, and if you find that hemosiderin level is increased, that means 100% you can say that there is destruction, abnormal destruction of RBCs. Right? Otherwise, hemosiderin level won't be, because it is packed inside. It is inside the RBC. RBC bichara toota to bahar nikala. Over here, now this hemosiderin is dark color. Macrophages ने खा तो लिया, but then what it is seen is बेचारा macrophage जो है वो भी dark हो गया. So this is a very beautiful image. This one is also this one, right? This one, this also, even this also. Three are to very good. They are macrophages, and छोटे थे तब कैसा बना देते? This is ये जो ये है पंडित का पेट, राइट? ये बैठा है और इसके अंदर क्या है? ये ज्यादा लड्डू जो उसने खाए. This is how we used to make, right? So exactly the same. Someone wrote the cookie in alveoli in you can say cookie. I love laddus. I used to explain like this. But yes, whether it is the laddu or it is your cookie, but actually it is like that. It is your cookies. Yeah, exactly. ये जो है macrophage में जो जितने भी these dark dots which you are watching, so these are the laddus eaten by macrophages. So RBCs broke, and that hemosiderin, that is C. So what are these called as? They are called as the HF cells. Heart failure cells. And in one word, scientifically you have to say that these are the cells, right? So these are the cells, hemosiderin laden, right? It means deposited. Hemosiderin laden macrophages. Hemosiderin laden macrophages. When seen in alveoli, they are called as the HF cells or the heart failure cells. Why it occurs? Because macrophages, they have engulfed, engulfed those extravasated. What is extravasated? Vasated means जो भाग के आए. Right? Those RBCs those who have entered भाग के यहाँ पे आए अंदर. Right? So extravasated RBCs. Extravasated RBCs. Are the macrophages already present where the exudate happens to be present, or they are triggered and then they come for the cytosis? Well, good question. Two things. There are some resident macrophages. Resident macrophages means कि अपने घर के बाहर वो एक बेचारा सिक्योरिटी जो रखा है, कोई इसको थप्पड़ मारे तो भी बेचारा रो पड़े, but है ना. So those resident macrophages, they are there, but in case of any bawal, right, that security can call the boss, यार मुझे मारा पर आप भेजो. Then those हट्टे-कट्टे they will come out. Same thing happens over here, right? When the resident macrophages, they send the trigger signal, so that is when this thing would be flooded with WBC, and then literally it is like as if they have sent the location, right? That system is so amazing. Means पता कैसे चले such a huge body कि कहाँ पे किसने मैसेज भेजा? No, there is a very fine location system, right? Seriously. So they come and ढूंढते अच्छा आए बस इतना दूर है. Literally like, right? In many of the movies you say that, oh, okay, two officers down, and then they say, okay, we are en route, ETA 1 minute, right? Expected time of arrival 1 minute, and then the same thing over. Exactly the same. The first line of defense, and then comes the second line of defense, which is with super powerful macrophages. So when they come, this is the work of those, right? They just eat away everyone. When this thing occurs, one thing is there, that this is because of the left heart failure. It's not a very good sign, right? It means the pressure has increased so much along with the inflammation that it has become the exudate. There is a more destruction, right? More destruction. So that's why these are called as the heart failure cells. There is exudate or inflammation. So RBC, when they break, they lead to release of hemosiderin. That hemosiderin is dark, but macrophages has already eaten. But so under jaake, right, all these laddus or cookies, that is how you really see. Because one macrophage is a big cell. It can eat away so many, right? Literally, it is like Pac-Man, right? It will eat away so many RBCs. Right? RBCs, so they are bacha in front. So that's how it really happens. Second, now this part, this is where I'm taking you for pharmacology. Important point is that recently I saw one very bakwas video. Right? Very, very bakwas video. When they were telling, means even एक advertisement भी आता. And when they say that ये डॉक्टर्स ने आपका लिवर खराब कर दिया और ये खराब कर दिया एंड ऑल दोस बकवास, देन आप हमारी शरण में आइए और सिर्फ 2 दिन में ठीक हो जाए. व्हाट नॉनसेंस. मींस जस्ट विदाउट नोइंग द हिस्ट्री कुछ नहीं, कुछ भी बोलते हैं. बट वेल इट हैपेंस. नाउ दिस इज which is like a sword, double-edged sword. You are trying to make one thing better, but do remember something else can go wrong. Now here it is. The patient has come. First, I'm not telling you anything about this part. मैंने नहीं बोलना था वो वर्ड, इसलिए मैंने नहीं बोला. Don't want to insult anyone. क्या करें? You're right. So here it is. Patient has come. And that patient is having cerebral edema, right? So, grossly, if I say this is the cerebrum and that's our skull, and then there is cerebral edema. When there is cerebral edema, so there is fluid collection, so it compresses the brain. When the brain gets compressed, so that is the major emergency. Because if the brain is compressed and if the brain gets damaged, तो फिर बाकी का body ठीक है तो भी it is of no use. So your prime responsibility will be to treat the cerebral edema first. So here is the patient of cerebral edema. Now from edema, you must have noticed, that means this is the extra fluid collection which has occurred in the cerebrum. But cerebrum, now cerebrum, it is controlling everything, right? All your movements. So if the cerebrum is affected, so that means your patient won't be able to, his entire motor system would be involved. Right? He'll be sluggish, he won't be able to move, right? Or unnecessary convulsion, all sorts of things can happen. So your aim is, for the good of the patient, what you do is, you inject mannitol. Now आपने inject किया, because it is cerebral. So as a treatment, you inject mannitol. From point A, we can't explain that. We just focus on this point. Because from point A, we talked so much about it. So just focus on this cerebral edema. Right? So when there is fluid collection into the brain, our prime thing is we need to remove that fluid. Mannitol is a drug. That's right. I just right. Yes, you are right. Mannitol is a drug. Right? Bottle. So intravenously it has to be. When you put it in intravenously, so this mannitol is nothing, but there will be increase in the osmolytes. Right? There is increase in the osmolytes, so they will call the fluid, right? So here there is increase in osmolytes in blood. So you can say that now there are more salts, so the fluid will attract the fluid. That's what we want. Right? That's what we want. So it will attract and things will be good. So brain will be happy. But in the process, what is happening? When this is happening, right? So can we say that fluid is getting added into the blood? So that there would be rise in result. There would be rise in blood volume. There would be rising blood volume. Rising blood volume, that will lead to what? There would be increased hydrostatic pressure. Correct? There would be increase in the hydrostatic pressure. When there is increase in hydrostatic pressure, there would be increase in pulmonary capillaries pressure, correct? When there is increased pulmonary capillary pressure, it would lead to pulmonary edema. Lead to pulmonary. That means this patient will become dyspneic. The dyspnea will say breathlessness. And at times patient, and it happens, patient tells, अरे वो तो आराम से सोया था, right? And अब उसको सांस चल रही है. डॉक्टर ने कैसा किया? अरे पहले वो आराम से सोया था because he was not in his senses. Now he is conscious, but because of this, there is a dyspnea, right? It has developed. And you are knowing it that it is going to happen, and that's why you are giving the oxygen, right? Well in advance. But they said कि डॉक्टर को कुछ समझ नहीं आया. पहले तो he was okay, अब ऑक्सीजन देना. So do remember, sometimes it is necessary to explain this thing to patient. And not only that, it is not only the dyspnea. Because there is increase in hydrostatic pressure, so that's why if you just see the foot, you'll find that there is slight swelling, because this thing will occur in the entire body, right? So it happens not only in lungs, but it happens in entire body. In entire body. So all those things, when the patient, suppose, goes for washroom, right? When he comes back, they'll say, right? There is edema. Yes, that would be pitting edema. It would be pitting edema. So you raise the legs, so then that edema will go away. But all these things, they can really occur. But you have done it for good of the patient. Many times, patients say, nahi, doctor ko samajh nahi aa rahi, ye hai, wo hai, and then they take discharge. Right? This is what I'm telling you, it really happened. Right? They took the discharge. They said that by evening he'll be fine, don't go. They went to some other doctor, right? And they gave some pudiya, pata nahi kya diya. And they said कि देखा कि आपको नहीं समझ आ रहा था, ये तो इन्होंने एक पुड़िया दी और वो सब ठीक हो गया. In any case, it was to be going fine, but then this thing happens. So it's okay. It is like whatever they decide, it's okay. But we should know that what can really happen. So this is a very, very typical thing. The third thing, we talked about first thing, that is increased hydrostatic pressure. Right? And in increased hydrostatic pressure, we talked about these HF cells, and in these HF cells, they are nothing but the RBCs which are exudated inside. Due to inflammation, they are eaten by macrophages. Macrophages, they are the big cells of our immune system. So they eat away so that they want to keep this area clean. In the process, hemosiderin is released because it is the iron of the RBCs, and that is what is seen over here. It is called as the HF cells. Right? And then the cerebral edema, in which pulmonary edema occurs, though it was not before, but now it has occurred. The third thing is, whenever there is decrease oncotic pressure, the moment I say decrease on oncotic pressure, few things should have or must popped up into the brain. Decrease oncotic pressure, that means decrease protein in the body. Consider the whole body. Does body dehydrate after working off alveoli? I mean, body dehydration? No. Body dehydration means when the overall water of the entire body goes out. Right? The overall body water. Here, from alveoli, it has come into the circulation. In fact, patient would feel better. Right? Dehydration means someone severe diarrhea, severe vomiting. Right? Don't force me to ban you. Huh? I'll not take your name, but anyone from this university and that university, don't do that thing over here. Okay? Because you have done it for the first time, I'm not telling anything, but don't do it again. Right? Over here, simply for studies, nothing else. So that's why I'm not right now banning. Otherwise, second time happens, immediately ban. Okay? कुछ प्रॉब्लम हो, want to ask anything, ask straight away. कुछ नहीं, right? Don't want to take anyone's name. But ये सब काम मत किया. Last time यही हुआ था. मतलब ऐसे ग्रुप बना देते हैं फिर. I am always interested, as if I'm talking to all of you one to one. जितने क्वेश्चन पूछे, नहीं कुछ नहीं, डोंट वरी. किसी ने वो बस ये वाला. So चलो, coming back to decrease oncotic pressure. Oncotic pressure means decrease protein in the body. In the body. So how protein can increase in the body? खाते ही कम है, right? नहीं ऋषिकेश, नो प्रॉब्लम फ्रॉम योर साइड. हाँ, जरा भी टेंशन, कोई प्रॉब्लम. Ayush, any of the class, don't worry. मतलब will be going for one full revision, right? So किसी का भी क्लास मिस हुआ है, आप जरा भी टेंशन मत. नहीं अनु, everything fine, good सीधा. So here it is decreased protein कैसे? High count. So that is what is called as the PEM. PEM stands for protein, energy, malnutrition. Right? Malnutrition. There is no harm in eating. The only thing, the harm is when it is a junk food. Right? So this is one. Person is eating less. Second, very obvious, liver failure, because liver is making the protein. So there is less production. Right? Or we talked, what was this? The kidney disease. Related to kidney. Which syndrome was it? Which syndrome? Let's see. Write down which syndrome. In which kidney is throwing the protein out of the body. Good way. No. Now that's critical. Nephritis नहीं दोस्त, nephrotic. ठीक है? Nephrotic. मतलब जब अपने, चलो आई जस्ट, आइटिस यहाँ पे भी आए ना, आइटिस मीन्स इन्फ्लेमेशन. ठीक है? आइटिस मीन्स इन्फ्लेमेशन. दिस इज नेफ्रोटिक. नेफ्रोटिक में क्या है? दिस इज द बाउमेन्स कैप्सूल, राइट? बाउमेन्स कैप्सूल. यहाँ पे these are the blood capillaries which are going in from here. These are the podocytes. podocyte में से वो फिल्टर हुआ. अच्छा, then it's right. Podocyte में फिल्टर हुआ, and here is that urine formation. That blood goes, and that is the urine formation. When these podocytes, which are they are injured, so that means it will just put that protein into the urine, and that goes, right? When we'll be discussing nephrotic syndrome, there are several causes. Some of the causes, they could be even congenital also, right? So in which the entire basement membrane that is destroyed, and large amount of albumin really goes out. So that's why in the routine, say urine test, we'll find albumin plus. So that's where you know that yes, person is losing this. So in kidney, right? Kidney, it is a kidney damage. So that is the nephrotic syndrome. In all these cases, there is decrease. Achha. Up till this point, though, it was more or less a sort of revision. Now we learn something which is classical for this, and that is for the, you can say, the actual happenings inside. What is really happening inside the blood? Does oncotic pressure reduce, change? यूरिन कलर, वेल यूरिन कलर नहीं, ज्यादा फर्क नहीं पड़ेगा. The reason is urine color depends upon the amount of water. Water तो वो वैसे फेंक रहा है, right? अब तो protein भी जा रहा है. So that's why the urine becomes what's called as the frothy, jag one. Right? So such patients, when they go to washroom, right? So that becomes the frothy. Even अब जो यूरिन टेस्ट कराएंगे पेशेंट तो उसके अंदर भी दे विल राइट. So actually happening inside, the first thing what is called as the VQ mismatch. VQ mismatch or VQ shunt, right? VQ shunt. The second thing, right? We'll talk about both of them. The second thing is there is decreased DLC. And third thing is there will be decreased surfactant. These three things, they are very different. Decreased surfactant, it is also called as the surfactant dilution. Surfactant dilution. We start with this first because it is easiest to understand. Surfactant, what is that? Surfactant is something which is released by those type 2 pneumocyte. Okay. So when those type 2 pneumocytes they are releasing bichara surfactant jara sa to hota hai, and then this extra volume of fluid is coming, so that surfactant will become dilute, right? Coming to this DLC, just fine part. Starting with this first thing, right? Surfactant wala to easy hai na. Actual happening, what is happening inside the lungs, that's what I'm talking about. What is happening inside the alveoli, right? That's simple to hai, itna complicated. Surfactant, this surfactant which was present over here, the importance of surfactant is what? To decrease the surface tension, because surface tension is what leads to collapse of the alveoli. So this surfactant which is released by type 2 pneumocyte, it releases, it is a fluid which will decrease the surface tension so that alveoli do not collapse. But now it has happened like because of extra fluid, वो dilute हो गया, है ना? पहले एक कप में आप 1 चम्मच शुगर डालते तो जितनी स्वीटनेस या वो 2 कप मतलब अपना चाय है, only 1 चम्मच शुगर, तो it will be diluted. So same thing happens. So effect of surfactant decreases. So now that's why lungs they can collapse, right? This is the reason that lungs can collapse because of this, or that flow, or that alveoli can collapse. So depending upon how much edema has occurred. Is this part clear? Surfactant wala. Right? Okay. On to the next one. This is what is called as the VQ mismatch. This is the best of everything. Right? It is what is called as the VQ mismatch. To understand this, type 2 pneumocytes. Pneumocytes means these are the pneumocytes. It is the whenever the protein is there, right? Even when you go to gym, पानी में protein डाला, when you shake it, तो वो froth नहीं बनता, झाग. The same thing. Right? So VQ mismatch are type 2. These are the type of cells here. Type of cells. Right? Type 1. These are the which are for the gaseous exchange. Type 2, which are for this. Type 1 is what is making that endothelial lining. Type 2 pneumocyte, those who are releasing the surfactant. So coming back to this. Here are the, now this is bit hypothetical. You just imagine a bit. Okay? So when we say V/Q, first we see the normal. So this is ventilation. Ventilation means ventilation. So that means how much oxygen is coming, how much breathe we are doing, how much oxygen is coming, right? Which is measured in liters. How much oxygen is coming. The Q is perfusion. Oxygen to liya, but then there has to be the blood, blood which will carry that oxygen to various tissues. So that is called as the perfusion. So normally they both are same. Jitni breathe li, jitna oxygen andar gaya, that much oxygen is carried by sufficient amount of blood to the tissues. So something, if we really draw, so this is like lungs, right? Lungs, and so let's say we breathe 5 liters. So this is 2.5 and this is 2.5, right? Randomly, right? And for our understanding. And the amount of blood which is there, so that blood is going and the blood is going. This is that much blood which can take this 2.5 liters of oxygen on both the sides. So this is V is equal to Q. Right? Ventilation, perfusion. This is V is for ventilation and Q is for perfusion. P not used because P is for some other purpose over here, right? So that's why the next alphabet has been used. So this is what is called as the VQ level, where they both are same and this is normal, correct? This is normal. So all good. Now for some reason, if it occurs like this one thing will be carrying so many concepts together. For some reason, it happens like this. Due to any sort of obstruction, only 1 liter of volume, the air which person breathes, going on the right hand side, and 4 liters is going on the opposite side. Over here, it is less, and on the opposite side, it is much, much, much more. Right? And then, even if it is normal, 2.5, 2.5. Above one is normal. This below is abnormal. This is abnormal. So this 2.5, so much of blood, but will this blood be saturated? No, it will be having very less oxygen strength, correct? Am I clear? Am I clear on this concept? Because 2.5 liter of blood is there, right? Which means so much blood which can take 2.5 liters of oxygen. But now there is only 1 liter of oxygen. So एक गाड़ी में बैठ सके उतने पैसेंजर हैं, ट्रक भेजिए, बस भेजिए. So bus won't be full. So this thing will say, we truck भेजी थी 25 लोगों के लिए, 10 लोगों को बिठा के खाली पड़ी है. This would be hypoxia. Hypoxia is less oxygen concentration, right? Less saturation. सबका meaning से less saturation, correct? Less oxygen concentration. Hypoxia. Acha. What about the other lung? This one would be telling कि दोस्त मैंने पूरी strength लगा दी, but there is so much of oxygen, मैं इतना तो उठा ही नहीं सकता. So then it will be coming back. It will come back as normal. 2.5 के सामने 2.5 at the most, right? Fully saturated, right? Fully saturated has come. Fully saturated blood has arrived. But बाकी की हवा waste, right? It went up. Exhalation में बाहर because it was not used. What would be the final result? The final result will be hypoxia. Because of this, यहाँ पे तो कमी है ना, So even if the blood is mixed, there is hypoxia. There is less. So here, in both the sides, there is a total mismatch between the amount of breathe which we take, that is ventilation, versus amount of oxygen which is carried to the tissue, that is perfusion. So this is what is called as the VQ mismatch. VQ mismatch. We are coming to that, right? In which abnormality occurs. Just hang on. So this is what really happens. How the body would be responding. This is still more. How come V equal to Q? Because see over here, this is V. Over here, V is 1 and this Q is 2.5. It is the individual. It is calculated, right? So much so. Right? So much so, even lobe-wise it is calculated. This time I have shown you in a very gross way. When we'll be discussing it in medicine, we'll be going lobe-wise. Right? Lobe-wise, it will be going into that detail. But right now, even if you understand this much, it is totally fine. So body responds it in a very different way. What body would do, jahan pe kam hai, now see what happens. Right? See what happens. Where there is less blood, right? Where there is less oxygen, तो मैं blood क्यों waste करूँ? Right? So this is body response. Why? Here there is only one, right? By contracting pulmonary vessels. So it will contract this pulmonary vessel by contracting pulmonary vessels. It will contract a pulmonary. So less blood will start moving. So this is what is called as the VQ mismatch, and in which conditions it can really occur. You already know that. It is very much common in asthma. क्योंकि होना क्या चाहिए? Narrowing of the respiratory system, right? So whenever the respiratory tree is contracted, is narrow, so less air is going. But when the less air starts going, so it can lead to this. Or can you think of other possibility? And that is, what if situation is like this? For some reason, the pulmonary artery which was taking the blood, right, that is narrowed. So over here now the blood itself which is going, that has decreased. Not the air. Air is normal. But the artery which is carrying the blood, that is narrow. Wait, right? So even that thing can occur. So this is what will happen in pulmonary embolism. Pulmonary embolism. So asthma, overall narrowing. Pulmonary embolism, one of the clot, it moves and it lodges into one of this pulmonary artery. यहाँ पे जाके that clot has set in that area is now not right. This is pulmonary embolism. The third very important, COPD, chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease. So this COPD, that is very common. Last is smoking, in case of smokers. Right? So those who are smoking, yes, they gradually develop chronic obstructive pulmonary disease. So it happens. The fourth thing which is very common in case of any of the collapse, which is called as the atelectasis. 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 Atelectasis is another fancy name of what's called as the collapse. So when that one portion of the lung has collapsed, so obviously that lung portion is now not carrying any oxygen, right? No air or very less air. So that is when the VQ mismatch can occur. And the fifth thing is our today's topic, and that is the pulmonary edema. Pulmonary edema. These are the 5 classical causes of VQ mismatch. How do you really measure this? This is not easy. It is in fact one of the very tricky things. And no one would be asking you this thing, that how to measure this. But we just understand one simple. And that thing is, after that we'll take the DNC, just end up. So this is measured by what there is a special method. It is called as the Mgmt. It is called as the Mgmt. Mgmt is that there are inert gases which are used. Right? Inert gas means it won't react. So all the gases like say acetone or ethane, then acetone is the most soluble. This is most soluble. So acetone, ethane, then cyclopropane. All these are gases which are to be used. The only thing which is last one is the sulfur hexachloride. Mgmt for measuring. Mgmt for measuring VQ mismatch. Hexafluoride, and this is least soluble. So this Mgmt stands for, this is I, this is G, this is multiple. Multiple inert is those who are not reacting. Gas elimination test. What it is done is that these gases, they are mixed into saline, right? And then it is injected. And then you just pick up the arterial sample, pick up the venous sample. So these gases, right? These gases plus saline or dextrose, right? Usually normal saline is taken 0.9% sodium chloride. That is the normal saline. Or the dextrose can be taken. And they are injected intravenously, and then you take the arterial sample and then you take a venous sample. Right? So in arterial sample, it is the oxygen, it is the gas which you have mixed, and you just measure how much it is there. Then as it will be passing into the alveoli, and in the alveoli gas exchange has occurred, so there will be drop into this venous sample. So you take this and then you determine the ratio. And you have to repeat this thing with various gases. So it's quite a long procedure, but this is, even if you just say Mgmt, multiple inert gas elimination test, which gases are used? Acetone is most soluble, sulfur hexafluoride is the least soluble. These gases, they are mixed with the normal saline, and it is injected intravenously. Obviously, it has to be injected intravenously. It can't be done intramuscularly. Yeah, you cannot tell the patient to pija. Right? That is also not possible. So it comes to artery, and then you measure the concentration. You measure the concentration, and then there are some calculations, right? Which is like a gas constant, etc. So there are some calculations, and then that will be determining the VQ. And that's where you come to know that whether there is any mismatch between the amount of, that is between the ventilation and the perfusion. So this is what is called as the VQ mismatch. The second thing, which is very typical, is called as the DLC. Very simple. The CO is nothing but it's carbon monoxide. Carbon monoxide. So this is diffusing capacity, how much it is diffusing of the lung carbon monoxide or carbon monoxide. It's called as the DLC. Why carbon monoxide? Carbon monoxide is toxic. Yes, it's toxic. But our hemoglobin, it has its duty is take oxygen, take carbon dioxide, right? So these are its duty. But carbon monoxide is its love. It loves carbon monoxide tremendously. So when carbon monoxide comes, it will not do even other. That is what really happens when there is carbon monoxide poisoning. It is because of that increased affinity. Carbon monoxide will be taking all the important seats and it will not allow oxygen or anything else. It will just kick out. So that's what it really happens. But over here, what we really want to do, that's our alveoli. Here is, this will be oxygen, this is what we really want to measure. So for that, this is the mouth. This is the mouth. So there is a device like this. From here, it is the carbon monoxide. So patient, and the nose is clipped. Nose is clipped. So in other words, it's not. Nose is clipped. So now person has to breathe through mouth only. So when the carbon dioxide goes, it will go into the lung, and then body will throw it back in expiration, so that will come out. And it is this machine which measures everything. It is a matter of just 2 or 3 breathe only, not much. So before any toxicity develops, in between test is terminated. So एक दो बार में कुछ नहीं, there is no harm. इतना तो मतलब you put the eno into the glass, and then when you are drinking, the acidity will, right? So that is carbon dioxide. Over here also, so that is also in very small amount. Here it is carbon monoxide, but only for 1 or 2 breath. Right? Just that done, right? Test is over. But then when you are, it is because this machine is taken. So it will measure in how much went inside, how much came out, right? And that would be the diffusion. Right? How much has really mixed into the blood. So if the alveoli are good, the amount of carbon monoxide which would be absorbed, that would be higher. So this is what is called as the DLCO, diffusing capacity of the lung for carbon monoxide. Why we are using carbon monoxide? Because if this is the maximum a lung can do, because it has got tremendous affinity for carbon monoxide. Right? So this is maximum it can really. And this diffusion, right? And yes, it removes, it kicks oxygen out. So that's why this is done for. Right? I'll just write down. It's done for 1 or 2 breaths only. And it's done for 1 or 2 breaths. Not much. So this capacity, whenever there is, now it's part of this, when there is fluid over here, so there will be decreased capacity of the alveoli to absorb the gas. So there is decreased DLCO in pulmonary. So this is the second important. Okay. Now I think it's time. Otherwise, patient's sign symptoms, that would be very similar to any of the respiratory disease, in which there would be breathlessness and all those sign symptoms. That is depending upon the pressure, and there will be dilation of the vessels. But over here, when you are managing it, just from the management purpose, for the management purpose, you need to decrease the blood pressure, decrease to decrease the blood pressure, you need to give your patient what's called as the loop diuretics. Loop diuretics. So they will decrease the blood pressure because the entire intravascular volume decreases by decreasing intravascular volume. So fluid in the body is decreased. Blood pressure decreased. Mgmt is management. Then second, this is a very special procedure. It is called as the positive. It is called as the P, that is positive and expiration. That is at the end of the expiration, you are giving the. This is the procedure. So you are giving oxygen, but at the end of the expiration. So as soon as patients start breathing in, you are giving the oxygen. So this will, what it will do, it will increase alveolar pressure. It will increase alveolar pressure. When the alveolar pressure will increase, so the fluid would be pushed out of the alveoli. It will go back into the lymphatics, because you remember it, that this particular fluid, when fluid is getting formed, it is by the scapullaries. When the fluid is taken away, as we discussed last time, lymphatics. So increase alveolar pressure, that will push alveolar fluid into the lymphatics. That is how talked about DLCO. Now is the time. For a moment. Here are the lungs. You see these lungs. This was the lung. This was the X-ray which was shown to you even before that also. The typical picture of pulmonary edema. It is what is called as the bat wing appearance. Bat wing appearance. Here it is. On this side. As if it is that bat, right? Over here, so it is seen very sharp. So this is a typical picture of bat appearance. Yeah. In the bilateral proliferative. Both the costophrenic angles, they are obliterated. So this is pleural. On the opposite side. Heart size? Heart size is, right now it is normal, but you can see some white structure over here. Well, that white structure is telling you that this is metallic mitral valve, artificial valve, and it is metallic mitral valve. So if this valve, surgery is done on the patient, that's right. Tabhi, this valve has been placed. And so much so, it was the open heart surgery step. Right? So the sternum is cut and then the entire chest is open. Right? And these are the metal sutures. Metal sutures. Sternum. Right? External metal sutures. They are there and then they are used to tie. watch for one more. So over in the previous X-ray, over here, this is on both the sides. Bat wing appearance is on both the sides. Over here is on one side. You can clearly see that in this much portion, that extraordinary prominence of bronchovascular marking. And over here, it is just this much, but it is spread across the whole. So this is asymmetric. Asymmetric bat wing appearance. Asymmetric bat wing. On one side is more, one side is less. Yes, incidentally, you can see the calcification also. Calcification is seen in the arch of the tongue. Pretty common, right? Patient is aged. Another thing which you can see is that see this white things, some markings. These are ECG. This gives us the idea case heart is compromised. And as such, you can see, you can really calculate this. Yeah, this is definitely cardiomegaly. These are very here. First thing first, the moment you look at it and you find that heart is normal. We measure this, and if we measure this, yeah, definitely this is B, this is A. This is not more than half of A. So heart is normal. Heart is normal. And bat wing appearance, yes, so prominent, right? So prominent they are seen on both the sides. Bronchovascular markings, they are so prominent. So this case, this is a case of non-cardiogenic. And this is pulmonary edema. So non-cardiogenic pulmonary edema. And the reason is kidney. Which is so not seen. Heart is normal, so therefore suspect kidney. Right? And that's why the USG abdomen. Right? This is to be done, and where you see the kidney size, shape, etc. One word of caution: you can never stamp that if the heart is normal, so then definitely there is no heart involvement. Sometimes it can occur later also. Okay? This you want to see? Okay. So this is non-cardiogenic pulmonary. If I zoom this part, this and this, there is one line like this, one line like this. They are called as the curly B lines. They are called as the curly B line. This curly B lines, they are the thickened septals. Now there are septa. I'll show you even better these curly B lines. So these are all, so in lungs there are lobes. So these are all thickened interlobar septals. All now see this. There it is. See the curly lines. 1, 2, 5. All these lines. All these these lines, right? You see there is all this. They are called as curly B. And when you see these lines, that means you are dealing. To be very specific, it is called as the interstitial idiom. And when you see these curly B lines, so presence of these curly B lines, that indicates L, F, no doubt it can occur even in some of the cases when the outflow is obstructed, especially when the lymphatics are obstructed. So can occur in lymphatic obstruction. Right? To be very specific, pulmonary lymphatic obstruction, so especially in case of sarcoidosis, etc. But it is rare. So curly lines. Watch this on the opposite side again, seen very nicely. Right? See this. And definitely see the airspace shadow seen over here, this, right, all this. As if these bronchovascular markings, they have become so prominent, the blackness has decreased and the whiteness has increased. So this is the increased shadowing, right? This is the alveolar shadowing. So there is increased alveolar shadowing. All these are impacts. All right, so that's it for. Just put this thing into our photo. So this week we shall complete the respiratory system, go for the revision. The next week we will be starting with the cardiology. Right? Thank you. And iPad or laptop? Laptop with workout. That's what I use it. I do have iPad, but iPad, this laptop is much better. Go through these X-rays, right? We'll be doing the revision later on. All right. Thank you. You can get this PDF. I showed you. This is the email address. This is the email address. Send a mail on this address. I'll send you the link, and all the PDFs they will be lying. Not only today's, but even all the past PDFs. Right? It is TILLURMBBS@gmail.com. Okay. Take care. See you soon.